there's a hell of a lot more to life and love and happiness than your income. And general practice is not about income, but it certainly is about doing something that makes you feel very good, being part of your world, being connected to your community, feeling that you've done something right, you've made a contribution.
Today's episode of Better Thinking Podcast is with Antonio Di Dio, Dr Antonio Di Dio, who's the AMA president of the ACT. Fantastic podcast talking about mental health, difficulties about the number of beds we have in hospitals to support people who are in acute care, and lots of other topics. At one point he even starts interviewing me, so I'm sure you'll enjoy that.
Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking, yeah, better thinking. Time to tune in. Let's go.
Very privileged to have Dr. Antonio Di Dio here for another episode of Better Thinking Podcast. Antonio is the AMA ACT president here in Canberra, and it's an absolute privilege to have his time, as I know he's an extremely busy man. So welcome.
Oh, thanks so much, Nesh. Good to be here, mate.
I'm so fascinated to find out a lot about your work, what you do with the AMA, but also your clinical practice in terms of particularly, mental health, how you go about treating it as a GP, and your practice as a whole as well.
Oh, look, thank you. It's something about which I have enormous passion. General practice, which I've been doing 28 years or so, is something that fills me with happiness and pride and frustration and misery and grumpiness and joy and all of the things in between. But it also has been accompanied, probably in the last 4 years or so, by an interest in medical politics and administration and how resources are allocated in Australia. So the AMA work allows me to advocate on behalf of doctors and patients and healthcare consumers. So that's been an enormous amount of fun too.
Yeah. Maybe if you don't mind, we'll jump straight into, I suppose, the advocating role. I know talking off air, talking about some of the complexities around how that kind of looks, what it looks like in policy, and the challenges from not only the GP practice world, but health as a whole. What are some of the complexities that you see, here today in Canberra and maybe the wider Australian population?
Thank you. Certainly, there are plenty. I guess one of the interesting things about our own particular demographic in Canberra is that we're evolving fairly quickly, and we have a very large and rapid population growth. As billboards outside your practice, I see that say, what are you going to do for the 410 new patients that moved into Canberra this week and every week? The second fastest growing suburb in the country last year was Penrith with 23,000 new people, but the fastest one was here in Canberra. Gungahlin, 24,000 new citizens in 2018. Extraordinary. So we do have a big increase in demand for health services every year in Canberra, and we're still a very small jurisdiction, and we're still running on templates that are understandably, even if they're less than 20 years old, they are way out of date for a population of 400,000 people. Many of my friends who actually went to school in Canberra lived in a town of 100,000 people. And the Canberra that they remember is very, very different. It's a Canberra where, anything south of Woden was a farm. So we really do have some big changes there. And as a consequence of that, the medical workforce, the psychology workforce, and the people who need their services all have big periods of adjustment and big changes to make in the way that they work and in the way that they meet demand. When you add to that the nature of the people who seek psychology services, it makes it more complex again, because they're not people who've broken their arm and have a very obvious problem. and have a very obvious and immediate need and have a very clear system where the people around them say, bloody hell, you've got a broken arm, you poor bugger, I'll take you to hospital. And a hospital says, wow, you've got a broken arm, we'll do an x-ray, we know what to do. We've got a series of algorithms and formulas about how we treat all of these things. In mental health, a lot of the time when people are mildly to moderately unwell, they don't even know they're unwell. When they become more unwell, they do, but they don't know how to access resources. They may be young, they may be poor, they may be infirm, they may have no access or language to find out how to access resources. And if they've got a hugely important and serious issue, they may be too unwell to access resources, or they may have a very well, clearly diagnosable and clearly treatable condition like schizophrenia or psychosis where the illness stops them from being able to access very limited resources. So there is in almost every area of mental health, and Canberra is a bit different, but in every area of mental health there are blockages and barriers to people accessing them. And we need to protect the doctors and psychologists that are working in the front line and support them. We need more of them. We need them to have more resources. But we also need to identify the specific issues that affect the individuals who suffer from these mental health conditions and match them up to the right service.
You mentioned barriers and blockages for accessing, and also spoke about maybe outdated templates. What do you mean about those templates? You know, what can we do better? What's the current state of affairs, the way you see it?
Yeah, absolutely. So think about surgery. Most of the operating theatres in Canberra were built in the mid-90s, not a long time ago. But surgical techniques have changed so dramatically in that time, and procedures and throughput policies and aftercare policies. And so a lot of the operating theatre technology is not fit for purpose now for what we need to do, but makes perfect sense 20 years ago. If you could imagine perhaps setting up you walking into an office today to see patients and do some work, do some banking, run your business. And the office was set up in 1994, before there was such a thing as the internet or personal computers. I mean, it doesn't sound like very long ago, but it is a long time ago. In terms of mental health, there are definitely obstacles in Canberra to the provision of best possible care. And that is in no way a criticism of the people who run the ACT or run ACT Health. They're actually highly competent, highly motivated, decent people. But the requirements for a rapidly increasing population, they need to be met. And I met with our mental health minister, Shane Rattenbury, only this afternoon before coming here, Nesh, and there's a person who is highly motivated to make this system work better with definite ideas and plans and appropriate consultations. The thing is, there is definitely a need for more psychiatrists in this town, more psychologists, more beds. And that demand lies directly in parallel with the perfectly reasonable demands of all the other sectors of the community, including those in health. So our resources are limited and we have to be very careful in how we allocate them properly. That doesn't stop us and people like you and me advocating on behalf of people in desperate need for mental health services.
Do you think it's a requirement that we I suppose in some sense, review how we deliver care until the resources become available? I mean, I was having a conversation just recently about the number of graduates coming out of universities for psychologists. And it's a very small number. At least in my eyes, it's a very small number, where I don't know if the number of psychologists coming out of uni is meeting the demand of what the community or maybe even what Medicare is able to uphold. It seems that way to me, but I certainly don't have, too great an insight. Is it a resources issue, or do we need to kind of look at delivery, or a bit of both?
Let me answer that in two parts, because it's obviously one of my real interests, this notion of manpower. In Australia, we've got about 106,000 doctors. We've got about 17,000 medical students. We have a massive...
That many?
Oh, we have a massive number of graduates, a tsunami of graduates coming out soon. And that pipeline is not going to shut down, not to mention the fact that we still import more than 1,000 doctors per annum on top of that. And we're working longer and retiring later. So in terms of those imbalances, there may well be some training of more and more mental health workers. But the great difficulty of that, Nesh, is that there may not. All of those kids come out with medical degrees, and then they look for jobs, and then they may get an intern job, and then they may spend 5 years as a PGY, which is postgraduate year 1, 2, 3, 4, 5, and they may get onto a training scheme, and they may, if they get onto a training scheme, qualify as a psychiatrist, but then they may or may not get onto a scheme, and they may not or may not get a job, and they've been in the system for 15 years, and they may not get anything at the end of it. Now, psychology and many of the other health professions have their own issues in terms of undersupply or oversupply of graduates. And you're right, are we training enough, or are we training way too many? And even when we train way too many, are there going to be enough jobs for them? Because the jobs for them are either going to be in the private sector, where they rent an office, put out a shingle and hope to God somebody comes and sees them or can afford to see them, or find a job in the public sector where they may not be employing at all. So that is actually the cause of an enormous amount of mental health problems in the mental health practitioners. I am the director and sole member of the Doctors Health Advisory Service in the ACT. That's a 24-hour hotline for doctors who are depressed or sad or anxious or in any way unwell. And that is another thing that keeps me busy and very stimulating and very enjoyable. And 20 years ago, the phone calls that I used to get involved gambling or alcoholism or overwork or a wide variety of things, but mostly these days it's just mental health issues. So that workforce is actually suffering some problems themselves. The other part of your question was about, I think, Nesh, how are we going to match up those people with the demand? I got that right?
Yeah, absolutely.
So the traditional model of care, which I'm a part of and you're a part of, and I know we like it, is that patients will either self-refer to a psychologist through word of mouth that they've heard is very good, or they'll see their GP, and their GP may or may not say, yeah, look, I think you need to see a psychologist, let's do a mental health plan, and you'll qualify for X number of visits to your psychologist in the simplest possible terms, 10 visits per annum from the time of this referral. And that really does work very, very well for a lot of people. The mismatch between patient need and resources comes from areas where a patient is unaware of their need for treatment. So, as you know, lots of mental health issues involve a lack of insight, where a person doesn't know that they've got a problem. Everybody around them knows they've got a problem, but they don't. So I think you, like everybody else, may have done that. How many criteria are there for narcissistic personality disorder? Is it 13 in the DSM-5?
So, you're doing better than I am. I can't
I think it's 13. And this comedian in the US a couple of years ago.
I was going to ask, how come you know so well?
Yeah. So this comedian in the US a couple of years ago got out the DSM-5 for narcissistic personality disorder, Axis 1 or whatever it's called,
Sure.
and just put up a photo of Donald Trump and just went through it. And very few people get 13 out of 13 or whatever the number is. And her quite astute observation was, if you've got narcissistic personality disorder, A, you don't know you've got it, or B, you don't care if you've got it.
Yeah, absolutely.
And I'm not saying anything about Mr. Trump, and I make no diagnoses of him or any other person in public life, but the reality is that for those people that you and I do share who do suffer from this condition, or the people around them suffer from this condition, they may not know or may not care whether they've got this problem, but the people around them are suffering immensely. So there is, or young people who live in absolute hell in their own head because they're the wrong gender, or they don't fit in, or they spend 3.5 hours every single night reorganising their shoes in the correct order before they can sleep because they've got obsessive-compulsive disorder and they don't know they've got it. There's a hell of a lot of people who suffer from significant mental health issues and don't know that they've got a problem. I'll never forget when I was a resident in emergency at Royal Prince Alfred many years ago. One of my colleagues would tap his ear and then his chin and then his chest and then his foot and then his elbow 13 times in a row, and then he'd do it 12 times in a row, and then he'd do it 11 times in a row whenever an ambulance came in. He was a very talented doctor and did a great job, but his OCD was so debilitating that he'd have to do this sometimes. He'd hide in the bathroom to do it. And eventually one of our bosses said, "Look, do you want me to write you a script? You'll be better tomorrow." And the poor guy wasn't better tomorrow, but he did get better very quickly with some intense psychotherapy and medication. And even he, a very highly trained medical practitioner, did not know what he had. So you've got a big lump of people who don't know their diagnosis. You've also got a big lump of people who know that there's something wrong. I'm a bit anxious. I'm a bit sad. I think I'm okay, but don't think it's bad enough to seek medical treatment. And you've got some resources which are working very well or which are a little bit overused and strained, but you've still got some resources that are underused. And by that I mean people who aren't lazy or who are not working, but their specific area is not being used. There are psychologists in Canberra who only do child and family work. There are psychologists in Canberra who only do trauma, who only do sexual assault. And it would be a terrible shame, I think, for those people to be doing general practice psychology. They should be matched up with their skill and the right patient. And in general practice, I have a very long list of people in my head who subspecialise in every possible thing. If you come to see me with a sore knee, I'll know which orthopaedic surgeon to send you to. If you've got a sore shoulder, it's not going to be that same person. It's going to be a different orthopaedic surgeon. Psychologists are the same. Psychiatrists are the same. And you do need to match people up with the right person at the right time. And that involves the person knowing to come and see their GP, the person knowing that there's something wrong that can be fixed, or listening to their family and saying, "Yeah, okay, I feel fine, but if you say there's something wrong, I'll listen to you." The person being able to afford that care, whether it's the GP gateway or the psychologist or the psychiatrist. The person being able to afford, even if it's free, all the other costs, taking a day off work to go and see a health professional, finding a car park, finding transport, and the person buying into their treatment. I can't tell you the number of people, Nesh, who've got through all of those first 4 or 5 things and then at the end of it saying, nah, look, I'm fine, I still don't need any treatment. I'll just struggle along and be miserable. So even before you start, you need to understand before building a system that mental health issues take an enormously protean and diverse canopy. Canopy. What the hell kind of word is canopy, Nesh? Jeez. Take an enormously diverse view so that we, in our clinical jobs, need to be able to capture it, need to be able to see what's actually happening, but also they need to live in a city where they know, where do I go? And obviously the model that I've been following since I was a boy was that no matter what's wrong with you, you go and see your family GP. And then that person can organise and appropriately refer to whatever service you need. The other group that we talk about a lot in mental health, but not enough perhaps, are those that are really, really, really unwell. People who are psychotic, people who have severe suicidal depression, people who need urgent medical care. There is
extremely acute.
Yeah, that's right. And there is definitely a strain, a significant strain going on in Canberra at the moment, with some unbelievably heroic psychiatrists working in the public system. I'm not exaggerating when I say that the vast majority of those people need an immense pat on the back, not just for what they're doing today, but what some of them have been doing literally in the trenches for 20 years. They do an amazing job and they're tired.
Absolutely. And I think the strain that's felt, I'm always so incredibly grateful in the system that we do have, particularly, for example, here in Canberra with the CAT team, crisis assessment and treatment team, staffed by psychologists and I believe psychiatrists as well, full-time, 24 hours a day, 7 days a week, all year round, Christmas, New Year's. And if someone's in absolute dire straight need, not only will they be there to take a phone call, but they will come out and visit that person wherever they might be. It doesn't matter if they're in their roof cavity, if they're standing on the edge of a cliff. These unbelievable people will go out, highly trained, experienced psychologists and psychiatrists and like, to attend to look after this person when no one else is around. But there's a huge strain on that service being available all the time. But how fortunate are we?
Yeah, you're absolutely right. We are fortunate to have them, and we're fortunate that there are enough of them working hard to take on that work and get the work done.
There's got to be burnout as well, right?
Oh, look, there definitely is in some people that I've heard of in that organisation, and they need a lot of space and support. They need opportunities for regular leave, and they also need the support that comes from having enough physical space and financially supported inpatient beds. So this is not me on my high horse, but I think it's fairly obvious to anybody who looks at a health system that when you see someone who has got a broken leg and needs surgery, or a broken heart and is incredibly mentally unwell and not safe to go home, that person, both of those persons, need to be in hospital. need to be supervised, given the appropriate painkiller and surgery for their broken leg, or given the appropriate medication and close supervision if they are not safe, if they are suicidal. So,
and part of that medicine would also be someone nearby who's compassionate,
absolutely.
kind, caring, so that this person's not alone.
Oh, yeah, so true, so true. And people who do come out of that experience will often remember, first and foremost, the kind human being that was there on the front line with them, doing the one-on-one overnight nursing. But what you need is a bed, a hospital bed for that person to be put into. And what happens if day after day, month after month, your beds are 100% full? What happens is that people say, okay, there's so many people down in the emergency department right now. I want some people sent home. We need to free up some beds. And the psychiatrists might be able to look at some of the patients in the beds and think, okay, well, you've been here for 5 or 6 days. You're stable. You're not suicidal. You're okay. You're safe to go home. We'll get somebody from our team to come and visit you tomorrow and the next day and make sure you're okay. But sometimes they look at the people in those beds and think, I can't send any of you home. And can you imagine how stressful that must be for those doctors? I can't send any of you home, but I have to send some of you home because there's people in the emergency department who need to be here. Now, in order to create more beds, each one of those beds needs to be supported by a building, by a bunch of nurses and ancillary staff and cleaners and the whole rest of it. So it's real estate and it's HR. And it's a ship that can't be steered very quickly. So in some of the conversations I've had with the ministers involved, if you're talking about increasing significantly the capacity of a hospital, that might take 2 or 3 years. They have to consult appropriately, they have to spend taxpayers' money wisely, and they have to respectfully talk with all the stakeholders, all the people involved in the medicine, but also all the people involved in other medicine and the people involved in ACT government itself. So it's not something you can do really quickly. And it's not something you can fix just by employing 5 new psychiatrists, because what beds are they going to use? You've got the same number of beds.
Yeah.
You know? I mean, that will fix a lot of the perhaps workload issues on some of the other psychiatrists. But the reality is that it's a ship that, even with the absolute best of intentions, and I have no doubt about the excellent intentions of the people running ACT Health, it's a slow process. By its very nature, it involves consultation and respect. So I really feel for the psychiatrists and psychologists working in the front line with really, really unwell people, the pressures they must be under are quite significant.
I think you explained it extremely well in that conflict scenario of we have to go out and free some beds, yet there are no beds to free because everyone is acute. And it's now a huge mental and psychological burden on the medical staff and those supporting those medical staff, because they still have to go home at the end of that knowing that there are no beds available and that some people have been sent home who are still in an acute episode, phase, period, whether it be on the physical or whether it be in the psychological space. There's great risk that then comes to the community around what happens for that person and that person's family and the community because of that.
Yeah, that's right. One of the ways that you can help that situation is to have really, really good systems. So I'll tell you what I mean by that. We've just had a review into bullying and culture in ACT Health. And it was very robust and it was very painful for everybody concerned. But the outcomes have been pretty good so far. A committee has been formed of which I'm privileged to be a member, and it's chaired by the Health Minister and the Mental Health Minister. And it involves the Director Generals of Health and some other key stakeholders. And the word system comes out a lot, and I'll tell you what I mean by that. When you have chest pain, you might be having a heart attack. It doesn't matter what country in the world you're in, what hospital you're in. It doesn't matter whether the person you're seeing is a junior first-year doctor or an old guy who's been around forever. It doesn't matter if the person you're seeing is kind and gentle or if the person you're seeing is a horrible, arrogant bugger. Your treatment is exactly the same. You'll have the same blood test, the same ECGs, the same 5 drugs, depending on whether or not you've had a STEMI or a NEN-STEMI, as they're called. Treatment is standardised according to evidence-based protocols. We know what's worked based on the research. Now, what we don't have in many, many hospitals, I would say most hospitals around the world, is a clear system, a clear algorithm of how to behave towards each other. How to treat each other with dignity and respect, how to treat our co-workers, how to treat our employees or our underlings. Nice people will always behave nicely. Buggers will always behave like buggers.
Sure.
So if in this mental health space we had systems and protocols, and to be fair to ACT Health, we do have many very good ones, then at the very least we can mitigate as much as possible any potential harms that come to people who are the victims of temporary condition we call bed block, where you just don't have enough beds. So, and the system does work very, very well for the most part because it's peopled by very good people. We, at the very last resort, we can find beds in New South Wales. We can get people to have highly trained and experienced psychiatric nurses visit them at their home that night, the following morning, the morning after that. We can get those people to correspond directly with the GP of that patient should they be well enough, organised enough to have a GP. Some of these people don't have an address, so you can imagine how complex that might be. So yes, there are systems, and some of the systems are quite robust. But a system is only as good as the support that it gets and the supervision that it gets. So good quality care, whether it's psychology or whether it's, podiatry, the best quality care comes from care that is supervised and that is accountable. You can look back on your notes and think, yes, I did the right thing. Yes, I was. Or if I didn't, why didn't I? Why didn't I do the best possible thing? Why didn't I follow guidelines of best practice?
Yeah, supervised and accountable to evidence-based practice that goes out and says, for a certain condition, we know it's best for a client, a person, a human being to receive, let's say, 16 sessions of one-on-one therapy based on a particular model, whether it be CBT or ACT, different models for different conditions, and then obviously the provision of supports thereafter to go out and ensure there's ongoing follow-up. As an example, making sure that there's some standardised, very well understood protocols that can then also be measured. We can bring in the universities and say, ANU, come on over. Let's go out and look at the, pre-post outcomes, the 6-month, 12-month measurables. How many more hospitalizations have there been? How many times these people seen their GP? What medication are they on? How many more acute situations have there been? and we can then judge whether that protocol is working.
Absolutely. I have a question for you, because you can't get away without being asked a question and being pinned down yourself.
Oh no, here we go.
Okay. Now, because I'm so old, I remember the government introducing the Better Access to Mental Health scheme years ago. And so initially I think it was 8 sessions, and then it was 6, and then it was 10, and then it was 18, and then it was 16, and now it's 10. 6 initial plus 4 repeat. And that's been stable for about 7 years or so. So my question to you is, if you've got a patient that I or someone like me has sent to you, they're going to need at least 12 or 16 sessions of CBT or ACT. They're not out of the woods. They're getting better, but they're not out of the woods, and they really need you. They've got 2 subsidised visits left, and they're not going to get any more for another 4 months. Now, are you going to space those visits out in a way that works out well so that they don't wait too long to see you before the next one? Or are you going to finish your course of CBT the way that evidence-based says it should be done in a particular way, and then that leaves them a gap of 3 or 4 months before they see you? How do you make that clinical decision?
Before I go there, and it's an excellent question because that's what we face all the time. I came into the system when it was 6 sessions with the provision of additional 6 sessions, and then in exceptional circumstances, another 6 sessions would be offered, which means a total of 18 sessions in a calendar year, which is pretty damn good. That model is an excellent model, and it's very close to what I believe is the evidence-based recommendations from the APS around how much care someone would need to get the proper provision of care. I think it's more than that, but 18 is pretty damn good. We're getting up there. Unfortunately, we're at 10 at the moment, and I appreciate that. There's there has to be some type of balancing of budgets and the like. I understand some of those decisions, but they're not based on evidence-based practice, and that is hard as a psychologist, and I assume that most other health providers experience similar difficulties in their work. In terms of how do I juggle that ethical dilemma, so to speak, there are times where I go outside of the protocol, which goes out and says that continuity can be quite beneficial. Now, look, I can probably go out and justify with a story or a narrative as to why my clinical judgment is correct, and I'm happy to go out and do that. But the truth is, there's data out there that shows what works, and there would probably be times where my clinical judgment goes out and says, I don't want this person to have that gap, that period, because I have concern for them. And so what we might start doing is spacing out the sessions. And so, as a psychologist, I'm quite excited when a client is referred in, let's say, September, because I'm able to go out and see them quite regularly, September through to December. And then come January, there's a reset of the available appointments. And so we can continue that work, which would be very much in line with the evidence-based practice model. But when someone's referred in January or February or March, we are now in a very different world where immediately my mind is saying, how do we support this person, particularly those who are in the acute phase?
Yeah.
Because when they're acute, you don't really have a clinical judgment to be made there to say, oh, maybe we can spread this out, because that clearly is not an option. And so you go through your sessions or available sessions quite rapidly. And unfortunately, sometimes it's not 2 months of time that lapses between sessions before accessibility is available. Sometimes it's 4 months, 5 months, 6 months. And I think that's where we start to see the bottleneck showing up in the hospitals, because they can no longer come and see myself under those provisions. They have to go elsewhere. And so, there's an awful lot of pressure on the other community sector. There's awful lot of pressure on GPs. I'm sure you would see a whole lot more mental health related clients come your way that are there really for counselling at that point and support. And so it places pressure which, could be used for other means as well. And so I think we just start juggling between ourselves, right? And so we struggle. And so it's a huge conflict. And I think that's a big burden, in our own minds about how do I support someone knowing that this is going to come to an end. And I have to actually kind of start working on my protocol is a 10-session protocol, which is not what my training necessarily tells me to do.
So your protocol is determined by the available resources.
Well, I think makes
perfect sense.
It's the only ethical thing I can do at that point. However, if the referral's later in the year, then I move closer towards what evidence-based would go out and say. And so, there are times where I might not be practicing. As a matter of fact, I don't think a lot of psychologists are practicing on, the clear evidence-based model, because we start stretching them out. And I think it's the only ethical way to do our work. It just sometimes means that evidence-based can't be followed because evidence-based doesn't ask the question of context.
Yes, totally.
And we're trying to obviously find, this balance between if we can provide evidence-based, and that comprehensive, thorough support, I genuinely believe we will see less hospitalizations and less costs and burden on the community, which will, be able to then provide those beds for when there are those acute periods. And so I think there is a model in there, a systems model that will provide better healthcare and at least in my eyes, and maybe I'm a bit naive, but I think there's a capacity to balance those budgets too.
No, you're absolutely right. I have a supplementary question, which I promise will be my last.
Okay.
But
now I'm being interviewed.
Absolutely. But this fascinates me. This absolutely fascinates me. Sometimes when you see a patient, say for example, they might have chronic lower back pain, and it was based on an injury that happened 10 years ago. And they've been seeing a physiotherapist or a Pilates person or a massage therapist or an exercise physiologist. Say, for example, a massage therapist. We'll use a real example that happened to me. The patient might see that massage therapist once a week. Over a 10-year period, that's 520 visits to a massage therapist. And the insurance company writes the GP a letter and says, hey, this is not curing the patient. This is not making the patient better. You've had 500 visits in over a decade. Please explain to us why this has any value at all. Otherwise, we're cutting off that particular form of treatment. And I talk to the patient, and the patient says, well, when I have a massage, I feel much better for about a week. It doesn't cure me at all. But for that week, I feel well enough that I can go to work. I can have a job. I can make money. I can pay my rent. I can feed my family. And so I say to the insurance company, you pay for the person to take Panadol. Panadol doesn't fix anything. Panadol just makes them feel better for 6 hours to 8 hours, and then they take it again, and then they take it again. There's no problem with taking medication. The insurance company's happy to do that, even though it only lasts half a day. But they don't want to pay for the massage therapy because it only lasts a week. But realistically, in this particular patient, that week is all they need to live a normal life. So that's my roundabout way of asking you, how many patients do you see that you think, I can cure this person? Or how many patients do you see that you think, I can't cure this person, but if I see them on a regular basis and I institute a well-known, evidence-based form of therapy that I'm good at least they can live a normal life. They might need to keep coming back to see me for a long time, but at least they can be well. What are your vague stats on that, Nesh?
This is probably best explained in terms of asking the question of how long do you parent for?
Well, I'm up to a lot. Dad, send me money.
You know, what's the value of ongoing parenting, right? You know, when you're a parent of 80 years old and your child is 60, do we stop parenting, or does that still have value for that person?
I had, sorry to interrupt you, but I had two gorgeous patients come to see me about 5 years ago. The wife was 100, the husband was 101. And the first thing they said was, we're worried about our son, who had brought them into the appointment, and he was 72 years old. You have no idea how depressing that was. Jeez. And I'm thinking, when's this 22-year-old off my books? So you were saying the 80-year-old and the 60-year-old child, yeah?
Yeah, so we know the value is there, and it's exactly what you say. This is about functionality. This isn't about symptom reduction, and I'm very clear about that. I don't work myself personally on symptom reduction. I don't care for symptom reduction because a lot of what we experience in life will never go away. When a client says to me, I have low self-esteem, what they're kind of describing is when I walk around in life, when I wake up and I'm brushing my teeth, when I'm cooking, when I'm doing the gardening, when I'm at work, there is a voice in my head that only I can hear, which tells me I'm not good enough, which tells me that I'm an imposter, which tells me that I should be doing better.
That voice has been cheating on me. That's terrible.
And what's interesting is that psychology has been able to observe that most of us are walking around with that same narrative but a different voice. So there is no way in the world that I'm going to take that voice away for anybody. So symptom reduction, meaning let's get rid of that voice, let's get rid of that narrative, is a ridiculous notion in my eyes. Right? So I can't go out and look at my clients square in the eye and say, we're going to remove the low self-esteem thoughts. If I could, I'd be receiving a Nobel Peace Prize right now, right? And the international airport would grow tremendously just for the 747s landing of patients or clients coming to see me, right? So clearly symptom reduction just doesn't work.
It's funny you mentioned that voice, Nesh. On Monday night, the mighty Forest Division 8, I didn't think there was that lower division, Division 8 tennis team had a draw with literally a bunch of old Sheilas. And it was great. It was great. And at the end of my match, I said to the lady that I was playing against, you know, despite the fact that I won that 6-2, every single point I kept thinking, when am I going to lose? I'm going to lose. Where's the next point coming from? I'm hopeless. And she said, I've been like that every tennis match I've ever played. And at one stage last year, she won 10 matches in a row and she still felt like that all the time. And I said, what are you doing? And you'll never guess, Nesh, she's a psychologist in Civic ACT.
There you go. There you go.
So if she can't fix it, none of us can.
Absolutely not. And hence why the question of how much support does one need? I don't think it's about very strict numbers. I think it's about functionality. How do we support human beings in living rich, vibrant lives that are difficult? And it's difficult to be human. Now, I don't believe in over-servicing. You know, part of my job is to go out and ensure there's no dependency built.
Yeah.
That self-management, self-care occurs because that's the best thing for the client. You know, it's not good for them to come to me over and over and over if it's not required. No different to a child doesn't go back to their parent all the time, right? They start having independence. They come up with new skill sets, new solutions, ways in which they're going to manage their difficulties and the like. They will utilise friends. They will utilise colleagues. They will utilise the passage of time. And then there's also time that they need to go out and ask for consult, for support. And that's what psychology offers. And there isn't a time where a parent says, you are no longer worthy of this support. A wise parent might go out and say, maybe I don't want to see you next week. We'll make it 10 days or we'll make it a fortnight to assist them to stand on their own feet again if dependence is being built. But that will be done clinically. It'll be a wise decision that a parent goes out and deliberately makes for the best interest of that child. And so as a psychologist, in some sense, I'm a parent. And so my job for my clients remains for my life. And I am their parent, at least the way I look at it, to look after them whenever they need that, and to do it with some wisdom. So I'm not sure if I've answered that question.
Oh, I think you've done so in a very charming way. I think it's lovely. Have you ever had that experience where an insurer has said, no more, you've seen this patient on X number of occasions and they're not cured? I should hope that.
Absolutely, all the time.
That's phenomenal.
And I'll tell you what. Maybe because I'm a bit of a stubborn ass or a stubborn mule, I don't cave into that type of pressure.
Mm-hmm.
Because as a psychologist, I need to be making a decision that's best practice. And so I will very, very, very happily say to anybody questioning that type of approach, I'll quite comfortably say, I appreciate your point of view. Having said that, if my client requires ongoing support, I'm only going to go out and recommend what I believe is clinically appropriate. When that's not the case, that's what I will be writing and that's what I will be advocating for too. But while it remains the case, that's going to be my position. I'm not here to advocate for the client because that's not my job. The client needs to do that themselves. But I am a professional and I need to make professional judgment, and I won't be bullied by anyone because professionally, because I couldn't live with it personally, because it's not how I am as a human being. Having said that, insurers within their own right to go out and deny any further payment or support to that client. You know, that's a matter for the insurer and the client.
Oh, indeed it is. Yeah. Well, thank you for coming on my show, Nesh, and answering my hard-hitting questions there.
Yeah, what else would you like to discuss?
Actually, if you do want to answer another one, I'm intrigued. I'm intrigued at the dynamic between private and public medicine. I've been doing this for a very long time, and defending and supporting doctors in both the private and the public sector. The AMA negotiates with the ACT government on behalf of the visiting medical officers. The VMO Association negotiates for them, but we do it as well because we have a very good understanding of their particular interest and a very good relationship with government. We also negotiate on behalf of the salaried doctors, even though they've got their own union called ASMOF. We've been negotiating an enterprise bargain agreement with enormous energy for a long time. And it's given me a wonderful opportunity to see the incredible hard work and commitment that comes from both of those groups of people and how they are both essential to a robust and healthy system. And I don't mean that in any mealy mouth political way. They really are absolutely essential because of the different skill sets they bring and the different availability of service and timing of service that they bring. Now, in psychology, in the ACT, my impression is that the majority of the heavy lifting, the actual numbers of patients seen day in, day out, would appear to be done by private businesses, private psychologists who have a significant amount of their billing subsidised by Medicare through their Better Outcomes scheme. So I was curious for your reflections, not only as a highly regarded psychologist and clinician, but also as a business owner who has to pay the rent, about what are the potential pitfalls when personal financial gain interferes, as it inevitably is going to do sometimes, with best practice and best provision of service to your patients.
I'd like to pass the buck over to you and ask how do GPs do it?
Oh, we have no ethics. It's fine. It's fine. I'm actually on the ethics committee of the AMA, and it's like putting a fox in charge of the chook house, I reckon.
Look, it's very, very complex, and I think there are some systematic challenges that come up, and I'll discuss one that often comes up. As a psychologist, I am providing a client with therapeutic care and support so that they can live a more functional life and find richness and vibrancy again while still living with discomfort and pain and whatever the circumstances are. And so my role in some sense is to be a counselling psychologist to provide therapy. And I often get a tap on the shoulder asking me to do an assessment. Now, an assessment can be quite lucrative. It can be something that can be charged out at quite a high rate. It's often bound up in whether it be a legal sort of space or it's a situation where a client can't avoid it. They require an assessment, and so any number could almost be placed on that, and so it's open to abuse potentially. My job, at least the way I look at it, is to say where I can get away with it, I'm not going to be the assessing psychologist because there's a conflict of interest of being an assessing psychologist and a treating psychologist. I've never assessed the client for the purposes of what I'm being asked to write a report for. I've only assessed them for the purposes of providing therapy, what's going to be best for them. And so there's a new question being raised. Now, I know that it's very attractive for psychologists to say, I can do that, fills up my calendar, my books, and can be quite lucrative. But I think, if I could speak of how I would like psychology to act, and I'm not suggesting it's not doing a fantastic job at the moment, but I would love to be able to say the counselling, therapeutic psychologists do that, and that we have another space that looks after the assessments so that we don't go out and have a conflict between the two. And so, you can see in there's often those challenges that come about how can I go out and balance a business and therapeutic care. What's made it easier for us specifically is we've got quite a number of psychologists, I think 10 or 11 at the moment. And so if a client comes in with a particular need and I am not the person to do that for them because there's someone better than I, for example, I don't see kids. I'll see adolescents, but to a certain age, but I won't see kids because, not that I can't, there's just someone more proficient, more well-equipped. And so I would be mad, and in actual fact unethical, to go out and see them if I'm not competent. But the issue is I could be competent or I could believe myself to be competent, but I'm still not providing the best service. And so I think it's really a hard one to ask human beings to go against personal interest where we refer out. But it's not even uncommon for us in this practice to refer someone outside of the practice, even though we've got lots of psychologists, because they might need something specific. And once again, that's so I can sleep, so that I can be happy in my practice. And I think that also means that our psychologists can also feel happy as well and do good quality work, but that's not always going to be available to some. So it's a hard balance, and as we know, sometimes maybe therapy can go on for an extended period of time just because without the insight. So I think it still comes back to our training, which is, I think psychology does exceptionally well with continuing professional development, ensuring that we're providing continuity of care, but within an evidence-based model, making sure there's no dependency being built, and if so, we recognise that and put in the provisions to assist that. So, how about in your world? How is that balanced in the GP world, where often, we have an employer arrangement, so we employ our psychologists rather than they're contractors, and that does change the relationship of how they deal with clients. I think it's at least in my eyes, I think it's a better model because it reduces the human conflict inside that's naturally going to be there.
That's a fantastic model. I like it very much, and I like your answer too. One of my jobs is I'm the Deputy Director of the Professional Services Review, or PSR, which is an agency that's separate to Medicare in the Department of Health that investigates potential inappropriate billing of Medicare by doctors or psychologists or anybody else who bills Medicare. And you would think that would be the sort of thing that makes me cynical about the motivations and billing habits of medical practitioners, but it doesn't. It represents only a very small minority, a tiny minority of practitioners who may bill inappropriately. Even some of them bill very appropriately. In my AMA,
I've got a story about that, by the way.
Tell me.
Not quite that. I'll jump in and then I'll let you finish.
Yeah.
Quite early on in my career, I was quite easily seeing 9 or 10 clients in a day. Because I love it, and I could probably, if I didn't have, my partner, my wife, it may have been 15 or 16 clients in a day. But very, very quickly did I get a letter saying, "Dear Mr. Nikolic, we're going to run an audit on your books from Medicare," which in actual fact is exactly what should be doing, because there must be something that triggers them to go out and say, is this actually occurring, or is this guy dodging up the books? And so at least that's that's the story I think that happened. I don't know if that's true.
I think that's probably exactly what happened.
So I think we have really good provisions in our system. I'm just assuming to make sure there isn't the abuse that it is only, the very, very, very few who are probably blatantly trying to figure out systems to, pull the wool over the system's eyes.
Very true, and I'm sure your story ended the way that most stories end, which is that you don't come anywhere near PSR. You get a visit from Medicare or even a letter, and somebody has and the reason you get it is that you are a statistical quirk. You might be in the top 1% of billing or top 1% of seeing people in the country, and they might identify that you're in a particular demographic, a young professional who absolutely loves his or her job and enjoys seeing lots of people and keeps good notes and good records and practices good medicine, and they say, you'll never hear from us again. Keep it up. Well done. So the people that
I'm happy to say I haven't heard from him since.
Yeah. The people that I sometimes see are far more egregious examples. But what's fascinating about it is that through advocacy for doctors in many of the other things that I do, I realise that the vast majority of doctors actually undercharge, undervalue themselves, work too hard, and don't put a fair price on their own service. And I find that immensely frustrating, but at the same time, I feel very proud of them, that those are the qualities generally of a much nicer and more decent human being.
Mm.
Many years ago, I was the treasurer for a few years of a group called the Medical Benevolent Association in New South Wales. It's been around about 120 years and collects donations from doctors and distributes that money to doctors in great need, usually due to medical illness or misadventure or not having enough insurance or all sorts of things. But one of the saddest examples that I remember was a practitioner who was healthy and had worked until a ripe old age and had turned up every day until he was well over 70 and yet was close to penniless. And he didn't have a gambling problem and he didn't do anything wrong. He just never charged anybody anything and did not place enough value on his own, the value of his own service. An incredibly loved and popular human being, and that in itself contributes greatly to a person's own self-esteem and happiness. But I just found it that I was in my early 30s at the time, and when I was sending this person financial support on behalf of our organisation, I just remember thinking that at some point we have to wake up in the morning and think, gosh, I've got a family, I've got bills to pay, and surely the people who I don't charge a cent, who spend $40 on a packet of smokes, must value me to some extent, surely more than zero. So I think that most doctors undervalue what they do because of decency and humility, and most doctors also try to do the right thing by patients who are struggling. Roughly 86% of all GP consultations in Australia are bulk billed. There is no cost.
86%.
86%. And the ACT is an incredible exception to that. Most states feature that number. The ACT is about 57% bulk billing. We have a significant shortage. Yeah, so that number is actually going up, and we have a significant shortage of GPs. And that tsunami of graduates, those 17,000 med students that are coming through the pipeline at the moment, only about 8% of them want to be GPs because they see it as...
Why?
Well, they see it as very unlucrative because they're not stupid. But also, there's a hell of a lot more to life and love and happiness than your income. And general practice is not about income, but it certainly is about doing something that makes you feel very good, being part of your world, being connected to your community, feeling that you've done something right, you've made a contribution.
I'm absolutely in awe of what GPs do, and I think that's because I see not from an insider, purely, obviously as an outsider, but I see general practice as being an awful job. I can't imagine having a time pressure of seeing someone who's in desperate need and trying to source a history and information of what has been going on in a very, very short period of time, then go out and try and provide what I would call case formulation.
Yes.
To figure out what do I think's going on here, and then very quickly provide an assessment of this is what the therapeutic approach is going to be. Let alone the risks that GPs have to go out and balance, because it's not some of these risks can be much greater in terms of medication or missing something. And so the pressure, then, well, let me continue there. Then I'm assuming you've got to write up your notes. You've got to go out and somehow communicate that to the front desk. You've got to go out and instruct the client what's going to be occurring, what your thoughts are, when you want to see them next, what's happening with pathology, and so on and so forth in a record amount of time. And I'm in absolute awe of that, because I wouldn't be able to do it. It's got to be a certain breed of human being who's willing to sacrifice, so much of them for others. It's just such a great public service.
Oh, it's very kind of you to say, Nesh.
And my apologies. And I suppose part of my question is, what does that then bring to the general practice world in terms of mental health? I mean, there must be awful pressures in that world that you've seen.
Look, there are. We probably have one of the highest rates of job satisfaction and happiness of most professions, and we definitely have one of the highest rates of depression, anxiety, and burnout. I don't know very many GPs who work full-time, face-to-face clinical medicine over a certain age. It's just too hard. But I do know that even on my worst day, there's always at least one victory, which is a delight. The general practice workforce has, in Australia, put up with a lot from government. But I like to think that with good advocacy, that is going to change. And in the most recent federal budget, there was, for the first time in a long time, first time in about 7 years, $0.9 billion allocated after years of our campaigning to grassroots general practice. It's not going to make much difference at all to GPs' incomes, but it will make a difference to some of the services that they can provide to their patients, and that's just as good.
Because it's going to be needed with the going back to the beds.
Yeah.
When there's no beds, they're not coming to see me.
Yeah.
They're coming to see you.
Yeah.
Right, because they're at the bed because coming to see me is not enough.
Yeah.
Right. And so that they'll have greater access to you. So once again, the big burden is placed in general practice. At least that's the way I see it.
Yeah, that's right. Touching on one of the things that you said before in relation to time pressures and packing and unpacking what we do, I'd like your take on this concept, which is it's almost like a glass that you can't fill. The average GP, I think, would work a 10-hour day, of which roughly 8 hours, 8.5 might be face-to-face contact. If they're a private billing GP, that's probably about 34 patients a day. If they're an exclusively bulk billing GP, that could be anything up to 60 or more patients a day. Now, I have at least 2 or 3 patients every day, sometimes more, who would very gladly take up my whole morning if I let them.
Mm.
Most people come in with a list. Most people are entitled to come in with a list. If they're going to pay $50 or more out of their own pocket on top of the Medicare rebate to see me, I need to give them value for money, and they need to feel that they've been loved and listened to and heard and respected and got value for money. And I like to think that that's what happens because the vast majority of patients keep coming back. So some people have an acute and deep respect for your time. Some people, either through not having that filter or just through their own enormous, bottomless need, could easily sit in your office for 2 or 3 hours every single day. I would suspect that you have a higher percentage of them than me, and I'm curious to know how you do what we refer to as housekeeping, how you give people all the care that they need as part of a evidence-based, consistent program of CBT or ACT or whatever it is, but still are able to vaguely run on time.
I don't run on time.
And neither do I. There we have it.
I think if I don't have a client booked in the next hour, by default, whichever client I'm with gets that time.
Very good. Very good.
And not necessarily all the time, because I have to have checks and balances and you know, have some self-care. But as someone who cares, you're there to the end. And so, you know, our sessions are a 50-minute appointment. I cannot remember the last time an appointment ran for 50 minutes.
Always more?
Always more. It's never been 50 minutes. We give ourselves 10 minutes for writing notes and other things. I tend to write my notes as I go, or I write them at a later time, or I hope that I get a cancellation or something, or it happens in the evening. And so that's just me, you know. That doesn't mean everyone else does it that way, but it's always a juggling act. And what's interesting is that part of why they do sometimes come is because they don't have that insight. You know, there are clients where you've wrapped it up. You said, this is great. Okay, so I'll see you in a fortnight's time. You're standing, you know, you're at the door, your hands on the door, you're turning the knob, and they're still sitting in the seat chatting.
Yeah, unaware of social cues.
No social cues whatsoever. You've almost got to go out and wrestle them out, sort of thing. And look, the interesting thing is to me, it's still about compassion, because these people still need love, and they're probably yearning for it. They can never feel heard, or that they've been fully appreciated, or they want to share more, and if it's a dependency thing, then, we can push that out. More often than not, it's not. It's not dependency. It's just the social cues are not as refined as for other people. So, you run late, but for those ones, you run a little bit later.
One of my business partners is one of my best mates, and has a very, very finely developed sense of humour. And one of her challenging patients has what we were talking about earlier, an almost certainly undiagnosed borderline personality disorder. And she knows that this particular patient has just about finished with her when, as she's leaving the room, she says, well, that was of no help to me and no value to me whatsoever. And then well, she's finished with me.
Well, we have the classic one where just on the way out, there'll be, and it's quite sad in some sense, there'll be the acknowledgement of suicidal thoughts.
Oh.
And that obviously puts a big handbrake to the whole process of what's happening, and you've got to spend that time. And it's very common in actual fact. We talk about it in supervision quite often. It's almost just left towards the end, and I'm not really sure why, but I feel privileged that they're willing to do so, because that's potentially a life saved. So you take that time, but it's fascinating. I've always kind of wondered, it's just kind of dropped at the end.
Oh yes, it's like the classic in general practice where somebody comes in with a list of 10 things and you're feeling generous and you'll say, look, let's do the first 7. You can have half an hour instead of 15 minutes because let's just be nice. And then as you're finishing and they're walking out the door, I say, well, anything else on that list? And they say, oh yeah, I've got this funny left-sided chest pain radiating down my left arm. And that's when you think I could murder you quicker than the heart attack. So you get very good at looking at the lists first.
And that's why we need more beds, right? Because we start injuring our clients.
That's right. Doctor-caused injury.
Antonio, it's been absolutely wonderful having you on the podcast, and I can't thank you enough for taking the time. And we'll definitely have to have you on, because you've definitely got a lot to say, and thank you for your service in part of the AMA, because I know you also not only represent general practice and medicine, but psychology and psychiatry as well. So thank you for that, and
well, thank you so much, Nesh. It's an incredible privilege to be here, mate. You're a real ornament to your profession in this town, and long may you prosper.
Thank you.